Hello, everyone. Welcome back. I'm Dr. Rehan Folarin, and it's great to have you join me for today's lecture on the anatomy of the thigh. So we'll be exploring together the this key structure, that enables movement and contributes towards the provision of stability for an individual. It also plays a vital role, in the circulation and sensation of the human body. So, before we dive in, it's another shout out time with our top achievers alert. So, a big round of applause for Tani Kanimudu Onyedamola. Yeah, who posted the first correct answer. So, Onyedamola, you were very quick and accurate. Congratulations. And as part of honorable mentions, we give kudos to these other sharp minds who also posted correct answers. Starting with Olumburi Tolulope, you did well. Congratulations. Next is Hassana Barua. Thanks so much for your nice comments. Congratulations for posting correct answers again. Same to Abdurazak Fatiha. That was a nice one. Keep it up. And next, we have a new feature that's Shoaib Alia. Congratulations for having the correct answer. So, special recognition to all of you as well who got all of the answers correct except one. So that's the only reason why you couldn't get posted here. So it's an incredible effort. I encourage you all to keep aiming high. Let's give everyone a big cheer because your participation is making learning interactive and fun. So keep up the great work, everyone. And beyond that, shout out again to Hassana Barua. Guess why? She shared this creative mnemonic. I think reading strengthens people. I think I'll take that as I think reading strengthens people. So this helps to remember the iliopsoas muscle, the tensor fasciae lata, rectus femoris, sartorius, and pectineus muscles as flexors of the hip joint. So great job. And I encourage you all to keep up the fantastic work and keep the mnemonics coming because it's a great way, to solidify concepts and to continue to make learning more fun. Remember, every effort counts, like I always say, and it's all part of the learning process. So ensure you don't stop engaging because it's a key to mastering these concepts. And I believe you understand by now that your dedication definitely inspires others and it keeps the interactive learning thriving. Don't forget, in the current lecture, there will be MCQs as well, in today's lecture. So ensure you stay tuned and get ready to participate. As for this mnemonic that was provided by Hassana, it's a continuation of, other muscles, other movements that have respective muscles. Like I told you the last time, you can drop your suggested mnemonic that helps to remember these muscles generally. I already provided during the core lecture P go go Q, for the hip external rotators. So you have many of those of them. It's just about being creative and suggesting something interesting. Okay, so specifically in today's lecture, there are going to be about 10 MCQs as well, spread throughout the lecture, like we always do. So at the end of the lecture, I encourage the first set of students, to compile all the correct answers and drop them in the comment section. Let's see who can get all the answers right first. So with that, we proceed into today's lecture where we have the following objectives for this session. First, we want to identify the anatomical components of the thigh, the femoral triangle as well, because these are quite crucial for understanding the function of the lower limb. Next, we'll explore the muscles, the nerves, the vessels, and the fascial layers of the thigh. And lastly, we'll correlate the anatomical knowledge with relevant clinical conditions as we go on, while also mentioning the surface landmarks, thereby providing you with the tools to understand how this anatomy applies in medical practice. So here you have on your right the thigh, particularly emphasizing the femoral triangle, which is the second leg of this lecture. So to begin with, the thigh region extends, from the knee, from the hip down to the knee, and is divided into three main compartments, as you can see here. It has an anterior compartment, which is all the way from here down here. So all of here is regarded as the anterior compartment, and you appreciate this in the cross section. So here is the region in a complete human being, and when you take a cut along this line, you have a view like this, with this part being the anterior part of the individual and this being the posterior part of the individual. So here is the cross section, and here is the anterior compartment, and here is the medial compartment, and that's because this is the left lower limb or the left thigh. Okay, while you have the posterior compartment spanning from here to here. So these compartments house different group of muscles, as you can see, with different functions and innervation. So on the other hand, the femoral triangle, which is the second leg of this current lecture, is a critical landmark in both anatomy and clinical medicine. It is located at the upper part of the thigh, as you can appreciate here. And this triangle is of clinical significance because it allows easy access to major neurovascular structures. And this is quite helpful, for diagnostic procedures and for therapeutic interventions as well. So let's now explore the fascia of the thigh. We have the superficial fascia and the deep fascia. The superficial fascia contains cutaneous nerves. The space you have here immediately after the skin, you would appreciate this yellow compartment, this yellow space between the skin on the external part and the fascia and the deep fascia, or the beginning of the muscles on the interior. So this yellow space in between, which is also seen here, a continuation of the gluteal region down to the thigh region, that is the superficial fascia. Okay, this thin yellow region. So that's where you have cutaneous nerves contained, okay, and superficial blood vessels and lymphatics. So this superficial fascia also serves as a conduit, for structures that are prone to injury, such as varicosities. When you talk about varicose veins, they are mostly located in the superficial fascia. So as for the thigh region, you're talking about the great saphenous vein. Okay, so the superficial fascia houses all of these. On the other hand, the deep fascia, also known as the fascia lata, is more robust, and it's also the fascia that helps to compartmentalize the thigh into the three sections we talked about, into the three compartments we talked about. So this fascia provides stability to the thigh and helps in the transmission of force during activities like walking, like running and the likes. So within this layer, this deep layer, is what we call the iliotibial tract or the iliotibial band, IT band or IT tract, which is important in maintaining the stability of the knee. Okay, remember, like the name suggests, it extends from the iliac crest, anterior portion of the iliac crest, down to what? Down to the tibia, right, down to the outer lip, lateral lip of the tibia. So that band is important in maintaining the stability of the knee. And additionally, the saphenous opening is a key feature of this fascia lata, and it allows for the passage of structures like the great saphenous vein through this region. So here is the saphenous opening. Here is the saphenous opening, and you have the cribriform fascia in that opening. And then you have the pubic tubercle right here. So remember, here's the iliac crest, and you have the inguinal ligaments running infero-medially. You also have the falciform margin of the saphenous opening. You have the great saphenous vein taking its course. You can see the yellow region we mentioned again. That's the subcutaneous. That's the superficial fascia, the fatty superficial fascia, and that's why it's colored yellow in both of these pictures. So in this anterior view and this lateral view. And here again, you can see on the lateral end the iliotibial tract, and the rest of the fascia being the fascia lata, which we have mentioned severally in this anatomy of the lower limb. And then, yeah, so here is still the deep fascia continuing into the leg region. In that case, you refer to it as the crural fascia because the word crus refers to the leg region. Okay, and on this other picture, the lateral end, in the lateral view, you appreciate better the fascia lata. the iliotibial tract, or the iliotibial band. That's what is squeezed here for you. And then this muscle that is inserting into the iliotibial tract, that's the TFL, the tensor fascia lata. Here again is the tubercle on the bulging out of the iliac crest, and you have the gluteal muscle showing there. You have the patella here. So this helps to appreciate the fascia that you have contained within the thigh. So in this clinical question that I have for you that we're starting with today, we are dealing with a runner who complains who complains of a lateral knee pain after going through a long distance training. And upon imaging, it reveals that there is tightness and some inflammation in a structure that is extending from the iliac crest to the lateral canal of the tibia. So given this clinical scenario, what is the most likely diagnosis? This should be an easy one for you. Here is the runner. So do you think it's the hamstring strain, the trochanteric bursitis, patellar tendinitis, or the iliotibial band syndrome? Let me know what your answer is. We'll meet where we do meet. So now let's examine the three compartments of the thigh. You can see the anterior compartment spreading all around here, and then so it extends from here down here, and then you have the posterior compartment color coded with this, I don't know what you would like to call this, beige or something, and then you have this green coded one, that's the medial compartment, and this means you are looking at the left thigh. Okay, now first of all, to start with, we talked about the fascia lata. That's this little white structure surrounding the entire region, and you notice that it branches inward as well. That's why we said the fascia lata is also helping in compartmentalizing the thigh into different sections, which we now refer to as a compartment. So it's a continuation. It's the deep fascia, it's the fascia lata, and then so because it's doing this function of separating the compartments, so this is referred to as the intermuscular septum. Okay, so the intermuscular septum is also a continuation of the fascia lata, of the deep fascia. So here is an intermuscular septum, and here is another intermuscular septum. Okay, and here is another intermuscular septum. So how do we know them or tell them apart? This one, we refer to it as the lateral intermuscular septum. This one, we refer to it as the posterior intermuscular septum, and this referred to as the medial intermuscular septum. That is clear. So the septi separate the compartments. Now let's look at the compartments one after the other. And just before we dive into that, remember this is the superficial fascia, right, that contains the subcutaneous tissues amongst other things, and the cutaneous nerves. So here is the skin. Now let's look deeply into the anterior compartment. The main muscles here are the quadriceps femoris, which is responsible for knee extension. And what are the quadriceps femoris? It refers to these four muscles. The first of them is the rectus femoris. Another one is the vastus lateralis, intermedius, and medialis. No sweat. The vasti muscles have literally the same surname, so to speak. Okay, so what separates them now is their location with regards to the reference, with reference to the body, to the side of the body that they are faced. So the most medial, remember this is the left leg, so it means this is the medial part of that individual, the medial section. So this is the right side of the left leg, and this is the left side of the left leg. But as for the individual as a person, this is going to be the region where the person's midline is. So the closest thing to the midline will be medial in this case, because we are looking at the left leg. So the most medial vastus muscle will be referred to as the vastus medialis. The most lateral of the vasti muscles is referred to as the vastus lateralis, while the vastus muscle that lies in between them is referred to as the vastus intermedius, as you see labeled. And etymologically speaking, the vastus muscles that's the lateralis, medialis, and intermedius. They derive their names from the Latin word vastus, which means great. When something is great or immense or huge, that's the meaning of vastus. So this naming reflects the large size of these muscles and their significant role in extending the leg at the knee joint. So that's the anterior compartment, but that's not all. So these four muscles we just talked about, the three vasti muscles and the rectus femoris are what we refer to as the quadriceps femoris. Okay, but that's not the only muscle you find in the medial compartment. We also have the sartorius muscle. All right, so the sartorius muscle, along with the vasti muscles or the quadriceps femoris, they help to flex the hip and the knee. Okay, so the function of the sartorius primarily is to flex the hip and the knee, and you have as well the iliopsoas, which is a little bit superior. The iliopsoas muscle, remember, is a combination of the psoas major and the iliacus muscle when they meet together, and then they continue inferiorly. But you appreciate this at a cross section that is taken at a higher level, okay, in the hip region. So, but this one taken at the superior thigh region or getting close to the mid thigh region, you won't appreciate the iliopsoas muscle. And the iliopsoas primarily flexes the hip. So this compartment is innervated by the femoral nerve and has blood supply from the femoral artery and also gets drained by the femoral vein. So we'll come back to all of this in a while. So this being the left leg and the left thigh and the lateral segments, so you can appreciate the iliotibial band here. So the lateral compartment of the iliotibial band. Now let's go to the medial compartment, which is right here. So after leaving the skin, the superficial fascia and the fascia lata, you can appreciate this main muscles here. So the muscles you find here are naturally the adductors muscles, the adductor muscles. So adductor muscles, and you find three of them here. So by the virtue of the shape, so all of these muscles, these adductor muscles, um, there are three of them. They have the same surname like we did for vastus. So what differentiates them is their shape now. So we have you have an adductor muscle that is quite long, okay, and that is referred to as the adductor longus. Okay, there is another adductor muscle that is quite large and its expanse is quite wide. We'll appreciate this better when we come to discuss these muscles in subsequent slides. Okay, and as you can readily appreciate, even in this cross section, it's quite large, and that's why it's named adductor magnus. Okay, there is another one, and that is adductor brevis, which is not captured in this cross section, but you appreciate that in subsequent slides. So these are the three adductor muscles. Okay, but apart from these adductor muscles, you still find some other muscles in the medial compartment, and that includes this gracilis muscle. Okay, and the gracilis derives its name from the Latin word gracilis, all right, which means to be slender or thin, all right. And this name actually describes the muscle's long, thin, and delicate appearance compared to other thigh muscles. All right, so this muscle, you find the adductors, you find the gracilis muscle, you also find another muscle close to the superior part of the thigh known as the obturator externus. So all of these muscles, so that's not captured here, but you'll see that in subsequent slides. So all of these muscles are responsible for adducting the thigh and stabilizing the pelvis. The innervation comes from the obturator nerve, and the blood supply is from the obturator artery and branches of the profunda femoris artery. All right. Next is the posterior compartment, and here we have the hamstring muscles. The hamstring muscles, they typically extend the hip joint and also flex the knee. All right. So by hamstring muscles, we are referring to the semitendinosus, the semimembranosus, and the biceps femoris, which has two heads. So it has a short head. So here is the short head of the biceps femoris. Here is the long head of the biceps femoris, and here is the semitendinosus, and here is semimembranosus. And take note, to not mix up the semimembranosus and tendinosus. Membranosus, when you are coming from medial, so the most medial is the semimembranosus, before then the semitendinosus. You appreciate this more in the posterior view of the thigh, as we'll come to in subsequent slides. So M before T in the alphabet, right? So semimembranosus before tendinosus when you are going from medial to lateral. M before T. So all of these make up the hamstring muscle. And the term hamstring has its origin from Old English as well as Middle English. So in the in English, it's the word originally referred to, the back of the knee or the bend behind the knee, and over time it came, so that back of the knee was referred to as the ham, H-A-M, okay, and over time it came to describe, the broader region of the posterior thigh. And from the German word ham, it means for something to be crooked or for something to be bent. So, and this reflects the natural bend you find in the knee. So the strings of that ham is referring to those tough tendinous structures at the back of the thigh that are coming from these muscles that we've seen here. So these tendons of the hamstring muscle, this tendon eventually became referred to as the hamstrings. Okay, and they can feel like cords, and strings when palpated. And gradually in Middle English, the term was used to describe the muscles and the tendons at the back of the thigh. And all of this, they cross both the hip and the knee joints. So the term apparently reflects both the location and the structure of these muscles and their tendons. And clinically, the term also got further popular. It gained more prominence in the context of injuries and surgical procedures, because the tendons are often involved in strains, or even in history they were severed in punishment or even to conduct some surgical operations. So summarily, the hamstring muscles comprising of these semimembranosus, semitendinosus, and the biceps femoris of both heads. So they take their name from the location being at the back of the knee, and then from the string-like tendons, that came from them. So this etymology emphasizes both the anatomical and the clinical significance. So take note of that. So these muscles you find at the posterior compartment, they are supplied by the sciatic nerve. The sciatic nerve provides the innervation to this compartment, and the blood supply comes from the deep femoral artery known as the profundus or profunda femoris artery. So summarily, this is what we have appreciated. This is what I have listed in this slide. Now you understand that in the anterior compartment, you have the quadriceps muscles. So you have the quadriceps muscles and the sartorius and the iliopsoas, and this muscle generally function to extend the knee and flex the hip joint. They are innervated by the femoral nerve, and the blood supply is from the femoral artery. In the medial compartment, you have the adductor muscles, that's the adductor longus, brevis, magnus, and then you have the gracilis and the obturator externus, and all of this muscle, by virtue of their location, they function to do what? To adduct the thigh and also stabilize the pelvis. They are innervated by the obturator nerve, and they are supplied by the obturator artery and the profunda femoris artery. And posteriorly, these you find the hamstring muscles there. And what do? They flex the knee and also extend the hip, right? And so they are innervated by the sciatic nerve and get supplied by the profunda femoris artery. So it's the next question time. In this clinical question, a patient presents with difficulty in extending the knee and reports a recent injury to the groin region. And then upon attempting the patellar reflex, the reflex was absent in this patient. So the most likely structure that is injured is what? Is it the obturator nerve? Is it the sciatic nerve? Is it the femoral nerve? Or is it the lateral femoral cutaneous nerve? drop your answer at the right spot, and then we'll have our talk afterwards as usual. In this case, in this next clinical case, the patient presents with a severe pain and swelling in the thigh after a high impact injury with worsened pain on passive movement, and the patient also has weak distal pulses. What will be the immediate management step for this patient? What will be this is what the patient is experiencing. Okay, there is severe pain and swelling in the thigh, and this was secondary to a high impact injury, and this could also happen when some hard blows and stuff happen to that part of the body. So what will be the immediate management step? By management step, we don't mean first aid, so take note of that, and that's me helping you out. This is something that has to be conducted under um, a um, guided and serene environment or guided setting. Let me put it that way and not give you the whole answer. So what will be done? Is it to administer analgesics and monitor, or apply a compression bandage, or perform a fasciotomy, or order an MRI? Let me know what you think. Okay. And next, yeah. So in order to just be of help, let me just answer this for you. So the immediate management step will be to perform a fasciotomy, and this is necessary in the case of compartment syndrome, which is what this patient is going through. So it's a condition where there is increased pressure in the fascial compartment, and whenever this happens, it compromises the blood flow and can lead to permanent damage to that region and making the muscles become necrotic at the end of the day if not promptly addressed. So the muscles have grown beyond what the fascia can contain, and that's why immediately a fasciotomy. By now you should be familiar with these two words. So tomy is to cut something, and that's why the word anatomy is derived from. When you cut something apart, which is mirroring the dissection that you go through in gross anatomy. So anatomy means you separate, you cut, and then open up and separate. While fasciotomy, you are cutting through the fascia in order to relieve the pressure, the intercompartmental pressure. So this symptom suggests the compartment syndrome, and it is a surgical emergency, and that's why I'm talking about immediate management step. So and it can lead to permanent damage if not promptly addressed. So this is what, after the fasciotomy has been done, this is what the kind of scar that will be left after that has been guidedly done. So there you go. I should have the mark for that, or we just make it a bonus for you. Okay, the next question. Here we have a soccer player with a groin injury and weakness in the thigh abduction, in thigh adduction, in the ability to adduct the thigh. So what muscle is most likely injured that makes this person unable to adduct properly? Is it the gracilis muscle? Is it the sartorius? Is it the adductor longus? Or is it the pectineus? Part of the answer has been mentioned during the lecture, and then you get to understand better what the correct answer is in subsequent slides. But I'm not telling you the answer to this right now. So now let's look at the specific muscles within each compartment. We have gone through a number of these muscles. So just appreciate this picture. Here is the iliacus muscle, which is coded green, or a deeper green, while you have the psoas major muscle, okay, which is coded a lighter green. So at this point, you refer to both of these as what? As the iliopsoas muscle. And that's why if you take a cross section at this point, you may not appreciate the iliopsoas muscle as part of the muscles in the anterior region or in the anterior compartment of the thigh. But when you take it a little closer to the anterior superior iliac spine, so you may find the tip of it, at the in the cross section. Now you also have this muscle, and that's the sartorius. Okay, the sartorius muscle, otherwise referred to as the talus muscle. So the sartorius muscle is derived from the Latin word sartor, which means tailor, and that's why the muscle is usually referred to as well as the tailor's muscle. That's because the name is associated with the muscle's role in enabling movement, that resembles the cross-legged sitting position that is commonly associated with tailors back then. Because historically, tailors often sat on the floor or on low stools in a cross-legged position like this whenever they are sewing. So that's why I kept this picture, this ancient picture of a tailor. So you see how these legs of the tailor are crossed, okay, and these are many other tailors sitting on this low bench and then in a row, all of them in that cross-legged position, sewing. So because of this role and this anatomical pathway that the sartorius muscle has observed from this ASIS running infero-medially is why it's given that cross-legged name as the talus muscle. So we have seen the iliacus, we've seen the psoas major, we've seen the sartorius, and then you have the rectus femoris, which is one of the quadriceps muscles, right? And then here with the color coding, you appreciate the vastus medialis, the medial vastus muscle. And then you've also seen the lateral vastus muscle, vastus lateralis. Naturally, you understand why you won't be seeing the vastus intermedialis here because it's covered by the rectus femoris. So the pectineus muscle is what you have here. So this is a picture showing the anterior muscle or muscles of the anterior compartment of the thigh, muscles of the anterior compartment of the thigh. Considered together, the four muscles are considered the largest muscle group, in the anterior compartment that are responsible for the flexion, the extension of the knee compartment. Let's now look at each of these muscles in the compartment with further detail. The psoas major muscle, you see the origin is from the posterior abdominal wall, particularly the transverse processes of the lumbar vertebrae, okay, and the adjacent bodies from T12 down to the fifth lumbar vertebra, from T12 down to the fifth lumbar vertebra. And then you see as well as the tendons arches between these points. So this is the point of origin of the psoas major, and then it goes all the way to insert into the lesser trochanter of the femur, right? And its major function is the flexion of the hip joint. Then the iliacus muscle arises from the posterior abdominal wall, particularly in the iliac fossa, and it goes to insert into the lesser trochanter of the femur as well. So that's why both of them are considered together. The iliacus is innervated by the femoral nerve, while the psoas major is innervated by the anterior rami of L1 to L3. The iliacus contributes towards the flexion of the thigh at the hip joint as well. Vastus medialis arises from the medial part of the intertrochanteric line, right, as well as from the pectineal line and the medial lip of the linea aspera and the medial supracondylar line. All of this goes then to insert on the quadriceps femoris tendon and the medial border of the patella. And its major job is to extend the leg, along with other quadriceps muscle. The vastus lateralis arises also from the femur, the lateral part of the intertrochanteric line of the femur, as well as from the margin of the greater trochanter. As well, it arises from the lateral margin of the gluteal tuberosity and then the lateral lip of the linea aspera. And then it goes to insert into the quadriceps femoris tendon down here. And the rectus femoris is arising, the straight head originates from the anterior inferior iliac spine. Here is the anterior superior iliac spine. The anterior inferior iliac spine is around here. So it's the point of origin of the rectus femoris. And then its reflected head originates from the ilium, just superior to the acetabulum of the pelvic bone. And it goes down to also insert into the quadriceps femoris tendon. It flexes the thigh at the hip joint. It flexes the thigh at the hip joint, and it also extends the leg at the knee joint. So looking at this expanse, and it's innervated by the femoral nerve. Then vastus intermedius also arises from the femur, particularly the upper two-thirds of the femur. The upper two-thirds of the anterior and lateral surfaces of the femur, and then it goes to insert also into the quadriceps femoris tendon. So you can see the vastus intermedius because it's covered by the rectus femoris in this picture. It also contributes towards extension of the leg at the knee joint. So these are these muscles. As for sartorius, from the anterior superior iliac spine, and then it goes to insert into the medial surface of the tibia, just inferior-medial to the tibial tuberosity. And all of these muscles considered together, I think these make up the muscles of the anterior compartment of the thigh. Next, the medial compartment of the thigh. So here you would appreciate the obturator externus muscle, which originates from the membrane of the obturator foramen and the adjacent bone, and then it goes to insert after passing underneath the neck of the femur, as you can see here. Then it attaches to the posterior aspect of the greater trochanter, and that's why it's able to help with lateral rotation, because it's coming from behind the femur. So it helps with lateral rotation and also adduction, like with other muscles you expect in the medial compartment. Then the adductor brevis is better appreciated here. You didn't see that in the cross section earlier. So the adductor brevis arises from the body of the pubis here. It arises from the body of the pubis and inferior pubic rami, and then it goes to insert, proximal to the adductor longus. So it attaches to the linea aspera on the posterior surface of the femur, right? And then, of course, it contributes towards adduction of the thigh. So it's an adductor muscle, essentially. That's its primary role. So adductor brevis because it's shorter than the ones that are referred to as the longus, like as you can see here, and then adductor majors. So let's talk about the adductor longus, which originates as well from the pubis and expands into a fan shape, which you can appreciate here, and then it inserts also into the linea aspera. It attaches broadly to the linea aspera of the femur, and upon doing that, it it also adducts. It's one of the medial adductors. It's one of the adductors in the medial compartment of the thigh. So it's longer than the brevis, and then that name is well deserved. Next is the adductor magnus, which is starting from here down here. So it originates, it has an adductor part. It's a very big muscle. So it has an adductor part, and it has a hamstring part. The hamstring part is more posterior. Okay, that hamstring part originates from the ischial tuberosity behind. Okay, it arises from the ischial tuberosity, while the adductor part is the part you find in the medial compartment substantially. I mean, it's the part you find medial. It originates from the inferior ramus of the pubis, as well as the ramus of the ischium. Okay, so it's the hamstring part that originates from the ischial tuberosity. Okay, and then this adductor part, you can see it's attaching to the linea aspera of the femur. It's also in a fan shape, and it's much wider in expanse than the adductor brevis and longus put together. So the adductor part attaches to the linear across the linear aspera of the femur, while the hamstring part attaches to the adductor tubercle and medial supracondylar line of the femur. So the actions, of course, both of them contribute towards adduction of the thigh, both the hamstring part and the adductor part. But particularly, in addition to that, the adductor part also contributes towards the flexion of the thigh, and the hamstring part contributes towards the extension of the thigh. So you agree that it's a magnus muscle, really. So the innervation, the adductor part is innervated by the obturator nerve as part of the medial thigh muscles, while the hamstring part, being more posteriorly placed, is innervated by the sciatic nerve. Okay, so this is illustrating the muscles of the medial compartment. Next, we have the the muscles. In addition to this, okay, in addition to this, we still have the gracilis muscle, and then you find in some texts the pectineus, also added. So the gracilis is often described. It's sometimes excluded from certain tables of medial thigh muscles because it has a dual function. I mean this gracilis muscle. So because it has a dual function and a role in the, so sometimes this leads to it being classified differently and not always included in basic anatomical overviews. So the gracilis is often described as a synergist muscle rather than a primary muscle of thigh adduction. So in some lists, the focus may be on the primary adductors of the thigh, in which case you won't be including the gracilis muscle because the primary muscles that are responsible for adducting the thigh are the adductor longus, the adductor brevis, the adductor magnus. So in this context, gracilis may not be included because its role in adduction is secondary to its function in knee and leg movements. Okay, so and then you also have the obturator externus, which we already mentioned. Okay, so and then the pectineus muscle. Both of them are anatomically associated with the medial thigh, but are sometimes excluded as well. So they are sometimes excluded as well from basic tables that are listing the medial thigh muscles due to their distinct roles, and functions or classifications. So as for the obturator externus, which is not which I showed in previous slides, it is a lateral rotator of the hip. So it originates from the external surface of the obturator foramen, like we mentioned, of the obturator membrane and the surrounding bony structures of the pubis and ischium before it goes to insert on the trochanteric fossa on the trochanteric fossa of the femur. So the primary function is, even though you have the obturator externus located in the medial thigh compartment, its primary function is lateral rotation of the hip and the stabilization of the hip muscles of the hip joint, and it plays a relatively minor role when it comes to adduction at the hip, which is the primary action that is associated with other medial thigh muscles. So this is why you may have it excluded at times. And then the pectineus as well, it is located in the upper part of the medial thigh, just below the inguinal ligament, which usually runs from the anterior superior iliac spine down to the pubic symphysis. So in this regard, you have the pectineus, despite being located in this upper part, it originates from the pectineal line of the pubis and then goes to insert onto the pectineal line of the femur. So the pectineus is a flexor and adductor of the hip. So it plays a role both in the flexion and in the adduction, but its action is also more versatile, as it can assist with medial rotation. So this is why you find it also sometimes excluded from the tables that are listing medial thigh muscles because it can be classified into multiple functional categories. So even though it's located in the medial compartment of the thigh. So it can be categorized as a flexor abductor in some lists that are focused solely on adduction. So let this not be confusing. So both the obturator externus and the pectineus are indeed part of the medial thigh, but their function diversity and their primary roles makes them at times excluded from simplified tables that are focusing strictly on adductor muscles of the medial thigh. That's just what I wanted to emphasize, as well as the gracilis as well. So, but in terms of which muscles do you find in these compartments, you can feel free to list the pectineus, you list the obturator externus, and then you list the gracilis as well. Okay, so now the muscles in the posterior thigh compartment, we already addressed this as well. So the biceps femoris, you see it better now in this posterior view. The biceps femoris having the long head, okay, while this is the short head of the biceps femoris. Here is the long head of the biceps femoris, and here is the short head of the biceps femoris. It has more like a purple color, underlying this long head of the biceps femoris. So you find it laterally. Here you are looking at the right thigh, and the semitendinosus muscle and the semimembranosus are also listed here, are also displayed here. So like I said, when you're arranging from the medial to lateral, so you come first of all by the semimembranosus, which is the greenish muscle here. So the semimembranosus is first encountered medially before then the tendon of the semitendinosus. So M before the T, membranosus before tendinosus. Even though when you look at the superior part, you see the tendinosus, but when you come inferiorly, you encounter the membranosus first because it's much larger underneath before then the overlying this semitendinosus that runs down here. So biceps femoris, the long head originates from the inferior part of the upper area of the ischial tuberosity, while the short head originates from the lateral lip of the linea aspera on the femur. And then it goes to insert, both of them go to insert on the head of the fibula, which is the lateral bone you have in the leg region. They are innervated by the sciatic nerve, like with all other muscles of the hamstring group. So they flex the leg at the knee joint, and they extend and laterally rotate the thigh at the hip joint. So as for the semimembranosus, it originates from the superior lateral impression on the ischial tuberosity, and then it goes to insert, as you appreciate here, on the groove and adjacent bone on the medial and posterior surface of the medial tibial condyle, while for the semitendinosus, it arises from the inferior medial part of the upper area of the ischial tuberosity, and then it goes to insert on the medial surface of the proximal tibia. So they all get innervated by the sciatic nerve. So this is again summarizing all of these muscles into their compartments as we have earlier discussed. Now to the nerves of the thigh, which we have buttressed earlier. So the three major nerves of the thigh are the femoral nerve, okay, the femoral nerve. This is the anterior view of the leg. This is the posterior view of the, let's say, the lower limb. So you have the thigh region and then the leg region here. So the femoral nerve is the first, and that's more, it originates from the lumbar plexus of the L2 and L3, particularly for L2, L3, and L4, L2 to L4. All right, remember when we discussed the branches of the lumbar plexus. So the femoral nerve is also one of those branches. Remember, immediately influencers go live, followers open up. So the femoral nerve is the follower there. and it's originating from L2 to L4, and it goes to innervate the anterior compartment muscles and provide sensory innervation to the anterior thigh as well. Then next is the obturator nerve. The obturator nerve is right here. So it arises from the lumbar plexus as well, L2 to L4. And this nerve supplies the medial compartment of the thigh muscles, as we have discussed. And then when you look posteriorly, you will appreciate the sciatic nerve. That's the biggest nerve in the body, and it originates from the sacral plexus, okay, with contribution from L4. So from L4 to S3, that's the origin of the sciatic nerve, and it innervates the posterior compartment of the thigh, and it divides into the tibial and common peroneal nerves when it gets to the popliteal fossa. So as for the lateral cutaneous nerve of the thigh, which you can see here, and the posterior cutaneous nerve of the thigh, so the posterior cutaneous nerve, you can see here, the lateral cutaneous nerve of the thigh. These ones are often excluded from the list of the main nerves of the thigh because they are purely sensory and do not innervate thigh muscles. Okay, when you innervate thigh muscles, that means you are having a motor function. You are innervating those muscles so that those muscles are able to contract. They are skeletal muscles so that they can contract and then they can move the bony part of the body. But when you say the nerve is purely sensory, it means it's just to pick up sensations, you know, which are, like the name suggests, cutaneous. Pick up sensations from those areas of the skin of the thigh. So these muscles, they have a more specific and localized sensory function compared to the femoral, sciatic, and obturator nerve, which are mixed nerves with both motor and sensory roles in the thigh. So these cutaneous nerve do not directly contribute to the major thigh movement, and that's why they are less central to discussions about the primary functional innervations of the thigh. So yeah, the other nerves too that are branches of the lumbar plexus, in case you are wondering, all of those nerves, they are anatomically present in the thigh, but they are often excluded from the primary list of thigh nerves because they do not directly contribute to the motor or significant sensory innervation in this region. So the nerves either serve adjacent areas or have a more localized function. So what's our question here? A patient reports numbness in the medial leg and also reports weakness in the ability to flex the hip. So if a patient presents with this, we've mentioned two things: numbness in the medial part of the leg, and then weakness in the flexion of the hip. So which nerve is most likely affected? Is it the obturator nerve, or the femoral nerve, or the sciatic nerve, or the saphenous nerve? Drop your comments, and then we know what's what you think the right answer is. And yet, my next question is asking about a patient with a history of trauma to the posterior thigh, presenting with difficulty in knee flexion and also difficulty in dorsiflexion. Remember, the superior part of the foot is called the dorsum of the foot. So when you bend the foot towards that dorsal surface, is called dorsiflexion, such as this pressing of the foot. So this is dorsiflexion. And when you bend the foot in the opposite direction, in the direction of the plantar surface, that's called plantar flexion. So in this case, the patient, because of having suffered trauma to the posterior thigh, now presents a difficulty in the ability to flex the knee, and also a difficulty in dorsiflexion. So which nerve is likely injured if this happens? The answer is right in front of your face. Is it the femoral nerve? Is it the obturator nerve, or the sciatic nerve, or the common peroneal nerve? Let me know what you think in the comment section. So next in our discussion is the blood supply and the lymphatics, particularly in the thigh region. The blood supply in the thigh region is provided by a number of arteries, but fundamentally it's provided by the femoral artery. Okay, the blood supply to the thigh region is provided by the femoral artery, which is the primary artery supplying the lower limb. So what you are seeing here is the abdominal aorta, which is a direct continuation of the thoracic aorta. The thoracic aorta became the abdominal aorta at the level of T12, and thereafter, at this point, at this level of L4, the fourth lumbar vertebra, you have this abdominal aorta bifurcating into the common iliac arteries, the right common iliac artery and the left common iliac artery. It's called common iliac artery because at this point it has not divided into the external and internal iliac artery. So the abdominal aorta, the common iliac artery further divides, at the level of the sacroiliac joint. You can see the junction between the sacrum and the ilium and the iliac bone. So at this sacroiliac joint, the common iliac artery bifurcates. It divides into two branches, the external iliac artery, which continues towards the lower limb, and then the internal iliac artery, which supplies the pelvic organs and some part of the gluteal region and the perineum. So this is the external iliac artery, which then continues downward to reach this. You can see this and this inguinal ligament. So the inguinal ligament you see running between the anterior superior iliac spine and the pubis and the pubic symphysis, or the superior border of the superior pubic ramus. So the external iliac artery, by the time it traverses this midpoint of the anterior superior iliac spine, it becomes the femoral nerve, the femoral artery. And so at this level of the internal of this inguinal ligament, the external iliac artery passes into the thigh and becomes the femoral artery. At this point, you can refer to it as the common femoral artery because it's yet to also divide. So it then has this proximal course. So proximally, the femoral artery begins at this mid-inguinal, just below this mid-inguinal point, which is midway between the anterior superior iliac spine and the pubic symphysis, right? And then it descends through the femoral triangle, okay, which is a region bounded by the inguinal ligament, which we'll come back to all of this. This is the second, that will be the second part of this lecture. So it's a region bounded by the inguinal ligament superiorly and the sartorius muscle, and then the adductor longus muscle, all the same. So within the femoral triangle, the femoral artery lies lateral to the deep it lies lateral to the femoral vein and medial to the femoral nerve. Remember VAN. So the vein is the most medial, artery is in the middle, and then the nerve is on the lateral side, VAN. So from the medial to the lateral. So once this happens, then in the mid thigh region, after passing through the femoral triangle, the artery enters the adductor canal, otherwise known as the Hunter canal, which is located in the middle third of the thigh. And then, so at this point, then at the distal course, at the distal end of the femoral, the femoral artery then passes through this adductor hiatus, which is an opening in the adductor magnus muscle, which we showed earlier, to enter the posterior compartment of the thigh. So after exiting the adductor hiatus, it becomes the popliteal artery, which then supplies the structures of the knee and the leg. So you would appreciate here that at this point, before you then have the femoral artery branching out, giving off its branches, it's eventually going to give the deep femoral artery, otherwise known as the profunda femoris. This particular one you see here, so this is the deep femoral artery, which is otherwise known as the profunda femoris. It's the largest branch, and it supplies most of the thigh muscles. Okay, so it gives rise to the lateral circumflex femoral artery. So the lateral circumflex femoral artery, that's what you see here. So that is a branch of the deep femoral artery. Before doing this, it gives us the superficial epigastric artery, which you can see here, right beneath the inguinal, the inguinal ligament. So you see the superficial epigastric artery, and then it also gives the superficial circumflex iliac artery. All of this from the common femoral artery. And then it also gives the superficial external pudendal artery, as well as the deep external pudendal femoral artery. Now, you later have the deep femoral artery coming out as a branch. So the moment you see the deep femoral artery branching out, the rest of the femoral artery at that point is referred to as the superficial femoral artery. That major femoral artery is known as the superficial femoral artery, the moment it has given off the deep femoral artery, which is the profunda femoris. Okay, so from the deep femoral, you see the lateral circumflex femoral artery. And from this lateral circumflex, you see this descending branch of the lateral circumflex artery. So from the same femoral artery, from the major femoral artery, which we can refer to as the superficial femoral artery now, you also have descending genicular artery, which is the part that would end up giving off, just before it becomes the popliteal artery. So genicular is also having to do with genus. Genu is also another word for the knee. Okay, so this is the genicular artery, the descending genicular artery, and then the rest of the main femoral artery continues as the popliteal artery. So, in summary, the femoral artery begins as a continuation of the external iliac artery at the inguinal ligament, and then it courses through the femoral triangle and adductor canal and transitions into the popliteal artery after passing through the adductor hiatus. So, it's a critical vessel, for a number of clinical scenarios for vascular supply to the lower limbs, and it forms the basis for several clinical procedures, including catheterization and bypass surgeries. So in terms of venous drainage, the femoral vein drains deep structures, while the great saphenous vein handles the superficial drainages. So here, it's similar to the course of the iliac, the external iliac uh, is corresponding to the external iliac vein, the external iliac artery, external iliac vein, common iliac artery, common iliac vein. Okay, internal iliac artery, internal iliac vein. The superior gluteal arteries, the superior gluteal veins. So all of those are directly corresponding. So similarly, you have this is the main femoral vein here, and then you can see the femoral circumflex vein. This is the deep femoral vein you see here. So here is the femoral vein continuing here. And then here is the great saphenous vein. The terms great saphenous and the small saphenous derive their names from the Arabic root of safin, okay, safina or sofin. So both of them are associated with stillness or being motionless. It's different from the word safina, which actually means ship. So, but when it is called a safina with the module of the sin, this is reflecting a word of stillness. So this Arabic word means that something is still or immobile or at rest. And that's why a ship that is at rest is what is called safina, different from the safina of a ship, which refers to a moving ship. And why are saphenous veins named this way? It's because they were historically believed to be veins that lie in prominent stationary position in the body. And that's because they are relatively visible. They are easily palpable under the skin as well, right? And those terms were actually contributed by the Arabic medical scholars and anatomists like Avicenna, known as Ibn Sina, who greatly, influenced some of the terminologies. While discussing the introduction to anatomy, we said most of the anatomical terms are derived from Latin and Greek, and then you have visions from Arabic and French. So here is another example of words that are of Arabic origin. The saphenous vein is from Safina. So, yeah, I think that helps to appreciate that. And the great saphenous vein gives the superficial drainage. It drains the superficial structures of the thigh. And lymphatic drainage includes the superficial and the deep inguinal nodes, which are crucial in monitoring for infection or malignancies. So here is another question. During a surgical procedure in the femoral triangle, excessive bleeding occurs due to accidental injury to an artery. So if we want to control the bleeding, what landmark or compression proximal to which landmark will be best in controlling the bleeding? We are already in the femoral triangle, and then accidentally there is an injury to an artery and there is bleeding. So if we are looking for a landmark to block the bleeding, to stop the bleeding, where should we aim for? Should we look for the saphenous opening? What are we going to be able to arrest from that point? What passes through it? Should we aim for something around the mid-inguinal point? Or should we aim for the femoral canal or the adductor hiatus? Compression to the blood vessel at which of these landmarks will help to control the bleeding? Drop your opinion in the comment section. So now to the femoral triangle. First of all, talking about the borders. So the femoral triangle is really an important anatomical landmark in the upper thigh region. Okay, and it is bounded superiorly by the inguinal ligament, which we talked about not long ago. So this line you see here is the inguinal ligament, right? So this is the superior boundary of it. And then the lateral boundary is the sartorius muscle, which we understand now why it is called the talus muscle, right? So that's the lateral boundary. And then the medial boundary is the adductor longus muscle, okay? So it's a space deep to the skin, so it has a roof. So what's going to be the roof? It's the fascia that is covering this part, and that is what? The fascia lata, right? The deep fascia of the thigh, the fascia lata. While the floor is going to be what? The iliopsoas muscle and the pectineus muscle. Those are the things above which you find these blood vessels or this content, right? So the adductor longus medially, the floor is formed by the iliopsoas and pectineus, while the roof is formed by the fascia lata. So the femoral triangle contains several important structures remembered by the acronym NAVEL. NAVEL. And this means femoral nerve, femoral artery, femoral vein, and then next here you have some empty space, and then you have the lymphatics. All right, you have the lymphatics. So that's the femoral navel. So this area is crucial for interventions like, cannulation and even surgery. So it's frequently used for those procedures. So we have appreciated virtually all the structures here, the muscles, nerves, you can see the bone. Here is the femoral nerve, the common femoral artery before it gives off the profunda femoris artery, that's the deep femoral artery, and then it continues as the superficial femoral artery, that's the main one. Then you can see the vein as well. This is the deep femoral vein, and then it empties into the common femoral vein, and then the great saphenous vein also comes to empty into the common femoral vein, which then continues superiorly. So we have appreciated all this. This is the femoral nerve, femoral artery, femoral vein, femoral nerve. Now there is another structure here, and that's the femoral canal. And that's the femoral canal, and enclosed within the femoral sheath. Okay, so, and you are noticing this part known as the femoral ring. Now, the femoral canal and the femoral sheath are both located within the femoral triangle, but they have distinct anatomical and functional roles. The sheath, as you can appreciate with this green, is a cylindrical fascial structure, okay, that surrounds the femoral vessels, particularly the femoral artery and femoral vein and the femoral canal. Those are the contents of the femoral sheath. So the sheath is formed by extension of the transversalis fascia and the iliopsoas fascia. So it helps to actually provide a protection to these vessels, and it allows for smooth movement of these vessels as they pass through the femoral triangle. So with this, we understand, we appreciate that the femoral sheath helps to provide protection, and then it contains the femoral artery, femoral vein, and femoral canal. So what's the content of the femoral canal now? Remember, we said the content of the femoral triangle includes navel. So we mentioned empty space, and then we mentioned lymphatics. Those lymphatics are actually contained within the femoral canal. So the femoral canal is the most medial component of the femoral sheath, followed by the femoral vein and then femoral artery. The femoral nerve is not within the femoral sheath. So the canal is the most medial compartment within the femoral sheath, and it's a small funnel-shaped space, that contains lymphatic vessels, and few lymph nodes, providing a route for lymph to drain from the lower limb. So the canal is also important in the context of femoral hernias, where you have abdominal contents protruding through this canal into the femoral triangle, causing a bulge known as femoral hernias. So the triangle is important generally. That's the femoral triangle. It's important because it contains structures that are involved in the vascular supply and the drainage of the lower limb. So on that note, you appreciate that the femoral ring is a small circular opening at the superior part of the femoral canal, and it plays an important role in the context of the femoral hernias we just mentioned. And it's the most proximal part of the femoral canal, and it marks the entry point for structures within the abdominal cavity to protrude into the femoral canal if hernias are going to happen. Okay, so we've mentioned that the importance of the femoral triangle generally, and its content and the clinical relevance. So next is for us to understand a bit about the surface anatomy. So understanding the surface anatomy of the thigh is quite essential for clinical practice. So the femoral pulse can be palpated in the anterior thigh, midway between the ASIS and the pubic symphysis. That's along the inguinal ligament. So midway between that, below the inguinal ligament, you can feel the femoral pulse, right? And then you can also feel the bulk of the quadriceps muscle. It's prominent here, the bulk of the prominence. So here is the iliac crest. The ASIS is appreciated here. The inguinal ligament is right here. Here is the tensor fascia lata, and of course, all these muscular prominences can be appreciated in a typically muscular individual than an asthenic individual. So, if you find a bodybuilder, you will readily appreciate this, or if you are one yourself, you can readily appreciate these structures. So, tensor fascia lata is right here. This is a sartorius muscle running its course. And then the great saphenous vein can be appreciated on the medial end. Here of the quadriceps bulk we mentioned, so the vastus lateralis is lateral here, and then the rectus femoris is the one in the middle, and then the vastus medialis is what you have on the medial part. So here you still have the vastus lateralis, and the vastus medialis here. So here is the tendon of the quadriceps bulk, okay, running close to the patella, and then you appreciate in the leg the fibularis longus muscle, the anterior border of the tibial bone, and then the tibialis anterior muscle, then the tibial tuberosity is right here, the great saphenous vein is here, and the medial malleolus and the lateral malleolus. And so this is on the anterior view. When you look at the posterior view, you can appreciate the iliac crest again, the gluteus maximus muscle, the greater trochanter, the iliotibial band, right? And then you have the adductor muscle bulk here. And then you have the biceps muscles, the biceps femoris muscle, the long head, as well as the short head, which is like slightly more lateral. Then you have the popliteal fossa here, the gracilis muscle, which we talked about, the tendon of it, you find it here on the medial end. Then you have the great saphenous vein on the medial, posterior medial region of the thigh. Then here are the gastrocnemius muscles, the medial head and the lateral head. You have the small saphenous vein, and then you have the fibularis longus and brevis tendons. Here, the calcaneal tendon, or the calcaneus, the Achilles, otherwise known as the Achilles tendon, and here is the calcaneus proper, the tuberosity of the calcaneus, and here is the the plantar surface of the foot, and this is the dorsal surface of the foot. So appreciating all of these regions is quite important clinically, for clinical examination as well. The femoral pulse is so important that it's often used, to assess the circulation of blood in the lower limb, especially in cases of peripheral vascular disease, or in case of trauma or surgery. It's also important for cardiovascular monitoring in case of performing CPR and emergencies where the radial pulse is difficult to detect, such as in patients in shock or patients with hypotension. The femoral pulse is usually palpated, to assess circulation generally. And it's also used as anatomists. The femoral the femoral pulse is commonly used to assess the perfusion of the lower limbs during emergency situations too, for vascular assessments, like mentioned, particularly where the popliteal pulse is also being difficult to assess. Perfusion for fixation of cadavers is also something that is for which it's important to be able to identify the femoral triangle, because the femoral artery is that large accessible vessel in the lower limb that makes it suitable for using cadaveric perfusion. So it provides a direct route to the lower part of the body and can help in perfusing the arterial system. So in the medial thigh, can be examined. You've seen the adductor muscles, especially during a resisted adduction. You appreciate the adductor muscles, and in the posterior thigh, you've appreciated the hamstring muscles, which are palpable at the popliteal fossa as well. So all of these landmarks are particularly useful for clinical procedures. Okay, so during a femoral catheterization, the needle inadvertently punctures a structure that is medial to the femoral vein. So I've kept a picture here for you to joggle your memory again. So you've seen the medial vein, the femoral vein. So the needle inadvertently punctures a structure medial to the femoral vein. What structure could still be medial to the femoral vein? So what potential complication might arise from such a puncture? Will it be a hemorrhage from a punctured femoral artery? Will it be an injury to the femoral nerve? Will it be an injury to the great saphenous vein, or a damage to lymphatic vessels or femoral canal structures? I think I have simplified that enough. So the next thing, let's now dive into some clinical conditions, that are related to the anatomy of the thigh, because understanding these conditions are quite crucial, for diagnosing and managing patients effectively, because they can significantly impact mobility and other functions. So we'll cover trauma-related conditions, infection and inflammatory conditions, neuromuscular disorders, vascular conditions, and hernias. So first, we have trauma-related condition, and one of the most common is hip and thigh contusion. Hip and thigh contusions. Contusions occur when muscles of the thigh are bruised due to a blunt force or a trauma, such as during contact sports or accidents. So this leads to localized swelling and localized pain and bruising. So you can see this person's thigh, and then if left untreated, it continues to get worse. Within 6 hours, you can see the bruise. Within 30 hours, it can be this. Then within 54 hours, look at this, and then see what it has become within 86 hours. So if not properly managed, contusions can progress to a more severe muscle strain or hematomas. And in some cases, repeated trauma may cause long-term weakness or limited range of motion. So the primary management involves rest, ice, compression, and elevation, as it's always said, rise. That is RICE for rise. Rest, ice, compression, and elevation in more severe cases. So, and if it's much worse, in some cases, physical therapy may be further needed. And then patients are usually managed, given pain management or and prevention of further injury. It's only in very rare cases that you need surgical intervention for such conditions. Moving on to infections and inflammation, one important condition to highlight is psoas abscess, right? Which is a condition in which you have infection of the psoas muscle. You have an abscess here, which can be primary or secondary to a distant infection, such as from the intestine or even from the spine. So it typically presents with pain in the lower abdomen, in the groin or thigh, and patients may also exhibit fear and difficulty while walking. So this is the coronal view, otherwise known as frontal view. Okay, so here is the abscess, and remember this is your psoas muscle. So if untreated, a psoas abscess can spread, causing sepsis or damage to surrounding structures like the femoral nerve that will further lead to other neurological deficits. And management is usually involving a combination of antibiotics and in some cases surgical drainage of the abscess. So if it's diagnosed early enough through imaging like CT scan and MRI, it's usually helpful or crucial for effective management. Next, we look at neuromuscular disorders, starting with quadriceps paralysis. You know what your quadriceps muscles are. So here is how a normal person would walk when the quadriceps are fine. For a person with quadriceps paralysis, which could be due to a trauma or nerve damage to the femoral nerve, it results usually into the loss of motor function in the quadriceps. And what do the quadriceps do? They help you to extend the leg at the knee joint, right? So patients may therefore have difficulty in extending their knee. Now you appreciate the role of the femoral nerve and the quadriceps during walking or when you are climbing stairs, like we tried to illustrate during one of the classes. So a patient that has quadricep paralysis will have difficulty in extending the knee with with a severe impairment in walking, and this would imply that the person would have anterior trunk bending, because it significantly impacts the mobility, and it requires assistive devices and even assistive gaits. The person may end up needing assistive devices like braces or crutches, and in severe cases, long-term muscle atrophy may occur. And that's why it leads to the cordyceps gait, which is what this person are, um, uh, are experiencing. So treatment usually involves addressing the underlying cause, whether it's nerve damage or trauma. So the physical therapy and rehabilitation are usually essential to be able to gain strength and make that part more mobile. And in some cases, surgical intervention may be necessary. Next is chondromalacia patellae. And this is another neuromuscular disorder that is related to thigh anatomy. It involves softening and degeneration of the cartilage. So here is the healthy knee. So, but in a patient with chondromalacia patellae, there is softening and degeneration of the cartilage beneath the patella. And this is often caused by overuse or misalignment of the knee joint or trauma, and it leads to knee pain, especially during activities like climbing stairs or squatting, and it can result in long-term disability if left untreated. So you can see the plain bone surface showing. These places are meant to be covered by the cartilage, so there's already arthrosis going on, and the cartilages are already degenerating. So that is the malacia. Chondro is the cartilage, and the malacia is referring to the degeneration. So you see exostosis happening here, and exostosis refers to abnormal growth of bone, which is often in response to trauma or developmental issue. And this is always leading to a bony protrusion like the ones you can see here. You can see the plain surface of the bone is here because the cartilage has eroded. So you see cartilage erosion here, and then the cartilage wear has happened. Cartilage splinter is referring to this fragment that has detached from its original position. Okay, and this typically usually due to degeneration of those cartilages. So all of this is what happens in chondromalacia patellae. So chondro, like I said, refers to the cartilage, while malacia refers to the softening or the degeneration. So chondromalacia patellae is more like a softening cartilage of the patella. So these are neuromuscular disorders. Um, uh, so vascular conditions are also critical to consider, and one of the most serious is a femoral artery laceration. And this usually can result from trauma, such as gunshots, wound, or motor vehicle accidents. So in any case, the femoral artery, being one of the major blood vessels in the body, can lead to a life-threatening hemorrhage if damaged. And this would lead to severe blood loss or shock and even death, potential consequences that could result if not addressed immediately. So it usually requires prompt surgical intervention to control the bleeding, and this may include direct, suturing of the artery or stenting, or in some cases amputation if the injury is very extensive. So, but in any case, early recognition and resuscitation is usually crucial in saving the life of such patients. And you also have here femoral vein cannulation. So it's another important vascular scenario to highlight. It's a procedure that is often critically, it's often used when patients are critically ill for the administration of medications or fluids, or even in hemodialysis. However, whenever the procedure is being done, inadvertent complications tend to arise during the procedure. It could be infections, it could be thrombosis, and the infection, if it arises, can lead to sepsis, while the thrombosis can obstruct the venous system, the venous return, causing swelling and potential pulmonary embolism if the clot dislodges. So it's usually managed by appropriate techniques and sterile precautions during cannulation process. So, and if complication arises too, they are managed through anticoagulation therapy for the thrombosis, or antibiotics if it's an infection. And in severe cases, surgical intervention may be required. And in the case of the chondromalacia patella, conservative interventions like administration of anti-inflammatory medications or rest are usually employed. And um, physical therapies can also, to ensure proper alignment of the knee is also done. And in rare cases too, surgery is usually required. So finally, let's discuss femoral hernias. There are different types of hernias that usually happen in the body. So umbilical, inguinal, femoral. So looking at the fact that we're talking about the thigh. So femoral hernias occur when a portion of the intestine pushes through a weakness in the femoral canal. So typically in women, due to their wider pelvis, and it presents as a bulge, like you are seeing here in the groin area, which is often painful or so tender to touch, especially during activities like lifting something or straining. So if left untreated, femoral hernias can become incarcerated, and this may end up leading to bowel obstruction in the patient or strangulation, which can be very life-threatening in some cases. So the definitive treatment for femoral hernias is surgical repair, but it's also important to have an early detection and intervention in order to avoid some of these serious complications. So whether you're dealing with trauma or infections or neuromuscular disorders or vascular conditions or hernias, a thorough understanding of this condition is always germane, is always crucial to the management, and it can make a significant difference in the prognosis of that patient. Also, we are usually advised, to undergo regular physical examinations and timely imaging studies, because they remain key in diagnosing these issues before they escalate. So our concluding questions is about a 50-year-old man who presents with a painful groin mass that is inferior and lateral to the pubic tubercle. What is the most likely diagnosis? Inguinal hernia, femoral hernia, lymphadenopathy, or saphenous varix? And our final question for this session, the patient is scheduled for coronary angiography. And during the femoral artery cannulation, the needle is placed too medially, and it enters an adjacent structure. Which complication is most likely? It's a similar question, but I have different set of options this time around. So is it thrombosis of the femoral artery, hemorrhage into the femoral canal, injury to the femoral nerve, or compression of the sartorius muscle? Which of these could be a complication? So drop your answer in the right segment. So to summarize, the thigh, we have understood that it's divided into three compartments, each of it with its own muscles, nerves, and blood supply, right? And then we went through the fascia, the superficial and the deep fascia. And you have the fascia lata providing structural support and dividing the thigh into those compartments. We went through the key muscles in the anterior, medial, and posterior compartments, which help in various movements, such as knee extension, thigh adduction, and hip extension. And then we went through the femoral triangle. Now we understand its boundaries and its critical contents, right? And we understand it as an important landmark for accessing vital structures like the femoral artery and vein, right? We also went through nerves and vessels and possible injuries, vascular damage, and what have you. We also listed um, common clinical conditions that are related to the anatomy of the thigh. So I hope you have had a nice time, because so that will be it for today's lecture, and I sincerely hope that you have had a nice time during the learning process. These are texts that you can consult for further reading and understanding. I'm sure you'll enjoy reading further now that you have a simplified basics. And I want to thank you for joining me in this lecture and for watching and engaging. And I'll be looking forward, of course, to your engagement after you have done this watching. I'll also be looking forward to your comments with the correct answers to all of the multiple choice questions. Remember, it's always important to keep the learning interactive and fun, and it's a way to keep it's a way to keep um, influencing others and inspiring others. So the first set of students with the correct answers will of course get a shout out in the next video. So don't delay, get your answers in as soon as you can. I hope you've had a nice time, and until next time, stay curious and keep learning. I wish you all the very best. Bye from here.